is Dr. Patrick Buckley. Dr. Buckley is a orthopedic surgeon, did his fellowship training in Vail, and Dr. Buckley has just joined our group. We're very excited to have him. And Dr. Buckley will be talking to us about meniscal injuries.
All right, good morning, everybody. Everybody can hear me okay? Okay, so again, a special thanks to Eric and the IT staff for putting all this together. As Eric mentioned, I am a sports medicine surgeon. I work down in Wall predominantly, so if anybody I haven't met, happy to talk to you afterwards. And my kind of task today is to go through an evidence-based medicine understanding of meniscus injury, really understanding how to treat them. And this is one thing where we really do have good level 1, level 2 data to help guide our treatments and understand really who are the best patients to indicate for meniscus repair, meniscectomy, or whatever really the best treatment may be. I have no disclosures on this topic. So as we start understanding the meniscus and talking about repairing them and treating injuries of the meniscus, we really have to understand, number one, what is the anatomy of the meniscus? And number two, what's the function that we have to potentially try to restore with that meniscus injury? So the meniscus really acts as a functional extension of the tibial plateau. It acts to deepen the surface of the condyle on the articular surface of the tibia. And in addition to offloading the cartilage and adding that ability to protect the cartilage, it also contributes to knee stability. So we think about meniscus injury a lot when we start talking about ligament surgery. We start talking about reconstructing ligaments. A missed meniscus tear can predispose a patient to having that repeat ACL tear. And so these are all things that we have to look for. On a coronal MRI, you see here on the bottom right, it is triangular in cross-section. And when you start looking at that cross-sectional anatomy, it's predominantly composed of type 1 collagen. And the whole goal and the whole purpose of your meniscus is really to transfer axial forces. So when we're standing here, the meniscus is really transferring axial forces circumferentially. And it does that through hoop fibers, and it's a concept called hoop stress. So you're able to transfer forces axially and then ultimately transmit that onto the cartilage throughout the meniscus tissue. To do that, it really has an important part of the meniscus must be there. Really, you have to have intact attachment sites to the bone, so the meniscal root is important, and any meniscus tear may impair the ability of that meniscus to do its job, ultimately function in both stability and load transmission. As you start talking about potentially fixing a meniscus injury, looking at the vascularity of the meniscus is something that's been really well described and is an important thing to understand. The vascularity of the meniscus is really broken up into 3 main zones, and it's talked about the red-red, red-white, and white-white zones. So most of the blood supply comes from the periphery of the meniscus. This is a study that is kind of a landmark article in the sports medicine literature by Dr. Anoski, and you can see the real rich blood supply in the peripheral area of the meniscus. As you start working centrally, though, you have more moderate blood supply in the the middle third, and then as you get into the central third, it's a relatively avascular tissue. The traditional thought for this is that if you're going to look to repair these, you really should be repairing peripheral tears and potentially resecting or debriding any tears that go into that central area. I would say that's being challenged, and there's good data to support repairing tissues, or at least attempting to repair, especially for younger patients, so that you don't lose the function of that meniscus. And there are good studies that, especially for this central third, that we weren't totally sure about the blood supply, that does have a possibility to heal, especially as we're learning and we're growing in the techniques to both biomechanically augment, so the way we fix these suture augmentations, those have improved, as well as biologically augment these repairs, with other biologic techniques. This central portion of the meniscus really gains its vascularity from the joint motion and from mechanical loading that goes on in the normal joint. We all know there's 2 meniscus. They are different, and there's important differences between them. Your medial meniscus is more semilunar in shape rather than a circular shape, so you can kind of see here on the bottom. your medial meniscus here on the right versus your more circular-shaped lateral meniscus. The medial meniscus has a relatively thin anterior horn, but a very broad posterior horn, and it has much less motion inherently than the lateral meniscus. So this is something that you can see tear a little bit more often. The lateral meniscus, is, again, as we talked about, is more circular in shape, and importantly has a very close association with the ACL attachment site on the tibia. So this is something that when we go to reconstruct the ACL, we really use this and we look at this anatomy and look at this relationship to help guide where we're placing that tunnel. Because as we're doing this, if we have a good, and there's a number of ways to do this, but if we have a good landmark to place the tibial tunnel in an anatomic position, then that's the whole goal. We want to recreate the ligament and place it exactly where it started. That allows us to start early motion after surgery. That allows that graft not to stretch out and ultimately get a better outcome for the patients. So to summarize, your meniscus really comes down to two main functions. It's all about load transmission, protecting your cartilage, and adding to joint stability. So they are secondary stabilizers. And this is not thought as much about your meniscus, but you do have important stability that you gain from your meniscus. So when you're taking care of a patient who has an ACL tear, a lot of times we'll look at their Lockman exam here, and you can see that in the top right. But when you have a patient who has a high-grade pivot here on the bottom video, those are patients that you want to be thinking about. Is there a posterior horn meniscus tear? Is there a meniscal ramp tear in the back? Because often that very dramatic loss of stability can be not just due to an ACL tear, it can be due to a meniscus injury as well. So for these patients, I have a very high index of suspicion to look for those, and then when they're there, to fix those. So we know that the meniscus, we know what it does, really. It acts as an important stabilizer to the joint, and it also acts to transmit and distribute load. Long ago, we realized that taking out the entire meniscus does have a consequence. It can lead to early arthritis, and it does make some sense that if you take away the kind of cushion pad of the knee, that you may increase the forces across the cartilage. So I'm going to use that as kind of an introduction, and then I want to talk a little bit about what these patients, what I'm looking for in the office, what their exam is typically like, and then I'm going to talk about really the controversy, because frankly, treating meniscus is one of those things that the pendulum has kind of swung over the last 20 years. We've understood really what the role for a meniscectomy is and what the right patient is and what the role for a meniscus repair is. And that's, I think, one of the important takeaways that I want to talk about today. Meniscus injuries and meniscus tears are very common. About 35% of people over the age of 50 may have a meniscus tear, but many of those patients, up to 2/3, are asymptomatic. So just because a patient comes in, and this happens all the time, they have a report that says, I have a meniscus tear, I think I need surgery, that does not mean that they have to go right to surgery, nor should they go right to surgery. There's a number of levels and number of nuances to really understand about that patient. It is more the rule than the exception for a patient who has end-stage and severe arthritis when they come in and have a meniscus tear. That often is not really the culprit that's causing their pain. If they have grade 4 or really severe arthritis, it's usually the arthritis and the cartilage damage more than the meniscus that's causing much of the pain. And as we start talking about meniscus tears, really there's a number of different types, and we treat them differently, and repairing them really comes down to understanding these different types. Certainly the most commonly repaired and most common tear that we see could be a vertical tear, and this is really in line with the circumferential fibers that you can see here. Bucket handle tear kind of goes down, and if the vertical tear propagates both anterior and posteriorly, that tear can actually flip just like the handle of a bucket. And those are the tears when a patient comes in with a locked knee or a knee that doesn't want to fully extend. They're locked out and they will get to about 10, maybe 15 degrees short of full extension. Those are the people that I'm concerned about this injury. If you're going to fix those, we want to get to those relatively early, because as the knee bends back and forth, it can chew up that tissue and make it harder to repair. So it's an important thing to look for and to find. Horizontal tears are tears that go through and basically split the meniscus in half. So you have a superior leaflet and an inferior leaflet, and many of those can be stable, and many of those may be treated very well with non-operative treatment. There's a couple other oblique tears, degenerative tears that can happen as the meniscus ages and doesn't have as much pliability to it. And then really the three at the end, I think, are things that I'd like to focus on at the end. And these are tears that I think we're starting to understand the importance of more. Hopefully you guys are hearing more about meniscus root tears. Is that something that you have heard of? Show of hands? Somewhat? Okay, how about radial tears? Okay, so these are what we're going to go over today. And how about meniscus ramp tears? Okay, a little bit. So these are, things that we're discussing and understanding the importance of identifying these injuries and ultimately potentially fixing them. Meniscus root tears are really where the attachment of that meniscus attaches to the tibia. So if you take the whole attachment of your meniscus off, then the whole rest of the meniscus is likely not functioning. And this has been shown in very good biomechanical studies. Ramp tears are tears of the capsule at the periphery and the medial aspect of the meniscus as it attaches to the capsule. And then radial tears you can kind of see here in the top middle. These are tears that are perpendicular to the fibers of the meniscus. These are important because all of the hoop fibers that are running in line with the meniscus tissue are disrupted, and thus really much of the main function of the meniscus is torn. So even though you have much of the tissue intact, if there is a radial tear that goes through it, the function of the meniscus usually is significantly impaired, and those are bad actors, and those are ones, especially for young patients, that can lead to early arthritis. So what do I look for in these patients? Want to know if they've had an injury? You want to really look for mechanical symptoms, and that really means locking, catching, popping. Oftentimes patients will say, my knee gets stuck in a certain position, I have to wiggle it around, and then I'm able to bend it or straighten it out again, and that's a mechanical symptom. Those tend to do quite well with surgery. You want to know about any sort of previous treatment. Have they had injections? Have they tried physical therapy? Have they tried any braces, any type of unloader braces? And as Dr. Swan mentioned earlier, the meniscus is inside the joint. So if there is an effusion or there's swelling of that joint, it does raise our suspicion that there's something going on inside the joint as well. On my exam, again, I'm looking for an effusion. I want to know what their range of motion is. If they have an inability to fully extend their knee, I'm concerned about a bucketed meniscus, especially for an acute injury. I'm looking for really pain where that meniscus is. So at the joint line, do they have pain medial or lateral right over the joint? And really, as you extend it posteriorly, oftentimes a posterior root tear or a posterior tear of the meniscus may be most painful just at that joint line in the back of the knee. We've seen a lot of patients complain of pain, especially when they load the meniscus in deep flexion. And there's a number of provocative tests. McMurray's and Apley's are kind of the two most common tests that we look for identifying a meniscus injury. Radiographs are very important, and it's very important to have these be weight-bearing. It's very common for patients to come in and have a supine radiograph, and you'll end up with a picture kind of like this top left one here. When you ask them to weight bear when they take the x-ray, this is the same patient. You can see that this is a very different discussion in my office for that patient. Significant degenerative changes, joint space collapse. There's very significant narrowing here compared to that on the left. For young patients, especially who've had a meniscectomy before, taking out meniscus tissue may lead to malalignment, and correcting their problem, really you have to understand what their mechanical axis is, so we can get long-standing x-rays and look for either varus or valgus malalignment. And ultimately correcting that patient's problem may involve possible osteotomy or something else that will address their alignment as well as their meniscus deficiency. And then certainly the mainstay of treating a meniscus and diagnosing it after a history and physical is an MRI. And there's a lot of information we can gain from the MRI. We can understand really if it's a stable tear, if it's an unstable tear. What does the articular cartilage look like? So is there a significant amount of arthritis? That's certainly important when we counsel these patients. And something that's probably a new concept, but we're beginning to learn the importance of is there any extrusion of the meniscus? Is that meniscus pushing out of the joint? As the tibia and femur are coming together, is it pushing the meniscus out of the joint? And I'll kind of draw your attention here. On the lateral side here, you see the meniscus kind of lining up very nicely with the tibial plateau. That meniscus is likely functioning quite well. If you look at an extruded meniscus, it's coming out, and very little of the meniscus tissue, although it's there, is actually working and functioning to offload the cartilage. You'll see edema here of the bone, and those are big problems, and those are important things for us to identify. When we start talking about how do we indicate these patients for treatment, how do we really best treat them, there's a broad range, and this is where I think it's important to talk about the evidence here, because there has been a pendulum swing when you look at the high-level evidence for these patients. So for me, for stable, small tears, I usually start with non-operative management. That usually is a combination of anti-inflammatory medication, physical therapy. Again, it's important to not just say physical therapy, but what are we really looking for those patients to accomplish in physical therapy? We're trying to address their kinetic chain. We're trying to address strengthening in not only their quad, but their glutes, their core, their lower back, and that often can offload and help improve their mechanics as forces are going through their knee. Patients, especially who have concomitant arthritis, a steroid injection is a very good treatment option for them. And if there is malalignment, either varus or valgus, an unloader brace is another option. That may be a good option for patients to have. I think one of the big takeaways from me for this talk is that for young patients, our main goal, and certainly at all costs, is really to try to save that meniscus. It's a lot easier for us to take it out and to kind of remove that meniscus tissue. Long term, though, there are consequences for that, and we're learning about those consequences. So for young patients, and the definition of young may be different depending on who you talk to, we really want to try to repair that meniscus if at all possible. In my opinion, going back to debride part of a meniscus repair is not necessarily a failure, because you are likely going to take out much of that meniscus tissue in the beginning anyway. So I try to repair these tissues if at all possible. And again, taking out that tissue does have consequences down the road. And with that point in mind, we traditionally thought mostly that meniscus repair was for that peripheral tear, for that area that had very good blood supply. But we're learning, and certainly we're pushing the envelope to try to repair tissue and repair meniscus in this central third and even the central area of the meniscus. This was a study that looked at 10-year outcomes. This was out of Frank Noyes in Cincinnati, and they reported about 2/3, 62%, had normal outcomes. If all of this meniscus tissue was taken out up front, then all of those patients would have a functionally deficient knee, depending on the amount of tissue that was taken out. But we can have success rates even with this kind of relatively avascular zone in getting that tissue to heal. So just because you have some repeat meniscectomies, I would not call that a failure. As we talked about, removing tissue may have consequences. You can see kind of a joint space narrowing here in a young patient. It's important to follow these patients, to talk about that risk of arthritis, and to have them identify if they have pain or swelling with activities. So as we start talking about the risk of arthritis, certainly many people have heard of meniscectomy, and we always wonder, like, what is that risk? How do we quantify that? And there's a number of good studies that have looked at that. This is an older study that looked at both early as well as 14-year outcome of athletes. Again, this is a more older technique, an open meniscectomy, but when you took out a significant amount of the meniscus, almost all of them had radiographic changes, but most of them were asymptomatic. So there are some consequences, and we have to really understand how to weigh those risks and benefits for patients. A couple other studies showed a 14 times higher risk of arthritis following a total meniscectomy. Again, this isn't common. Most people are not taking out all of the meniscus, but if you do, these are kind of the problems that we look at. And we know that taking out or trimming a small amount of the meniscus may be very reasonable to prevent that tear from propagating and prevent that meniscus injury from getting worse. And we know that the amount of forces that cartilage is seeing is proportional to the amount of that tissue that's removed. This is kind of an interesting study that looked at NFL players who had an ACL reconstruction as well as a meniscectomy. Two different surgeries, so ACL reconstruction alone, or if an NFL player just had a meniscectomy, and their career length was not affected if they had an ACL, but if they had a meniscectomy, they had a lower amount of time left playing in the NFL. So, these are high-level athletes, and just having some part of their meniscus taken out is an important thing that affected them. What about repair versus a meniscectomy and their risk of arthritis? This is a study out of AJSM that looked at radiographic follow-up for relatively young patients, age 31, and their results at 9 years showed a higher amount of degenerative changes radiographically. This does not mean symptomatic, but radiographically with a meniscectomy versus a meniscus repair, and a higher return to sport with repair. So, I think the first myth I'd like to address is I have a meniscus tear and I need surgery. I think for a younger patient, we try to fix those, and we would be a little more aggressive with those. But patient who has degenerative changes, who has some mild arthritis, this is something where we have wiggle room, or have options we can offer that patient. And it's important to look at their age, to look at their amount of arthritis that they have, and really counsel them on the options for them. Mechanical symptoms are important to look for, so that locking, catching, popping, things like that in your knee. Those are things that may get better and tend to do better with surgery. But when you really look at the long-term studies, and that's what I'm going to go over, non-operative management does have a role for patients with a meniscus injury. So there's a number of really good level 1 and level 2 studies, and these are studies that really changed, I think, the way we've practiced and what we're doing for these patients. So the first I'll highlight was the study in 2013, again, New England Journal of Medicine. These are broad readership journals. These are high-level studies. This looked at arthroscopic partial meniscectomy versus just basically making incisions and doing nothing. And they found no difference for patients at 12 months. Another study, level 1 study, no arthritis, middle-aged patients. Therapy does the same as arthroscopy at around 5 years. So you may think, well, why am I hearing about meniscectomy? Many of those patients who have tried physical therapy may not get the pain relief they want. And so in this study, a third of them did cross over from the therapy group to surgery, and they did have good results. So, I think this is really the sweet spot of where my practice is for patients who have degenerative tears, maybe some very mild arthritis. It's very reasonable to try therapy and injection, brace, and if you don't get better with that, that would really be the time to consider, going in for possible surgery. Another study by Katz, again, New England Journal of Medicine, 2014, another level 1 study, looked at age over 45, mild to moderate degenerative changes. Again, no difference in 12-month outcome. But again, there was about a third that crossed over who initially were randomized to therapy who wanted surgery because they weren't happy with the results, and they did have good outcomes from that arthroscopy. Also, higher treatment failure with therapy. So there's a select subgroup of patients, and really the challenge to us is identifying who's going to do well with surgery and who would do very well with non-operative management. This was another study published last year. It was a randomized trial called the ESCAPE trial that looked at, again, physical therapy versus early surgery for patients who had non-obstructive or non-mechanical symptoms from their meniscus tear. Over 300 patients, 45 to 70 years old, and had 2-year follow-up. They, again, found no difference in the overall outcomes, but again, pretty consistent. About a third of these patients ultimately elected to have partial meniscectomy, did have good outcomes from that treatment. So these are their kind of outcomes. Again, you can see that the outcomes are relatively the same when you compare those two groups. So, overall, I think that a meniscus tear is important to identify, but you have to look for concomitant arthritis. Again, this is another landmark study that looked at arthroscopy with debridement of that meniscus tissue versus just basically running fluid through the knee and not addressing any meniscus surgery, or just making those incisions and doing no surgery, and no difference, right? So these are important things we have to think about as we counsel patients and try to identify and indicate the right patient for surgery. When you start looking at systematic reviews of this, again, this was a study in AJSM out of 2016. No difference between non-operative and arthroscopic meniscectomy as a first-line management, but there is evidence to support for patients who aren't happy and have continued symptoms after a reasonable course of possibly therapy and injection, to ultimately they will do well and ultimately is a good option to indicate them for surgery. So what do I do in my practice for kind of a degenerative meniscus tear, active middle-aged patient? I try physical therapy, I try anti-inflammatory medications, try a cortisone injection first. Many patients get better with that, and ultimately, just because they have a report that says I have a tear doesn't mean they have to have surgery. But for patients who don't do well with that initial treatment, that's when I would consider a meniscectomy and ultimately trying to address those mechanical symptoms and their continued problems that they haven't gotten better with therapy. So let's talk about other surgical treatment options. Again, the goal with partial meniscectomy is really to debride that meniscus tear back to a stable base. Many tears may be able to be left alone, especially in the setting of an ACL reconstruction. There's good data on that. When you talk about meniscus repair, there's a couple techniques. The first is an all-inside repair. There's a couple commercial devices that allow you to do this without an additional incision. I would say the gold standard would be an inside-out repair, where you make an additional incision and you're passing needles above and below the meniscus to repair that meniscus tissue back to the capsule. Again, it's another incision, so there is some morbidity and some potential risk to that, but the ability to have the biomechanical strength is improved with that. And this is what that kind of would look like afterwards. You can see the meniscus here, inside-out sutures going across it. Outside in is another option, where you take a needle from the outside of the knee and ultimately repair it in that direction. And we're beginning to learn, and the techniques are developing to repair the meniscus root, or the attachment site of that meniscus in the back as well as in the front of the meniscus. And I'll talk about that in a second. So, this was a tear that is really the optimal tear to repair. This is a very peripheral tear. You can see a probe going through here. This is at the very vascular zone of the meniscus. This is a tear that, in my opinion, really should be repaired. It's a large amount of the meniscus that would have to be taken out. And this is a tear that should do quite well with a meniscus repair. They do have higher healing rates with concomitant procedures. When you drill tunnels, you release much of the healing factors from the bone. And we're able to really optimize that biologically with other techniques that have been developed. So doing what's called kind of a microfracture of the notch, where you take a non-articular part of the femur and ultimately try to bathe your meniscus repair in the stem cells and bone marrow tissue, can increase your healing rates, and there are good outcome studies that have looked at that. Again, the healing rates vary, but it can be higher with an ACL reconstruction. And so in the setting of that, I would push the envelope a little bit. Even for a more central tear in the setting of an ACL, it does have a higher chance to heal. Typically, we repair especially those outer and central 1/3 of the meniscus. And the goal is really to provide the meniscus tissue to be next to each other in a stable manner, so that your body can then heal it in that position. These are just a couple studies that have looked at tears that traditionally we thought maybe were a little more difficult to heal. So bucket handle tears, the outcome studies were the same as vertical, or kind of the more gold standard repairs for vertical meniscus repairs at 2 years. And then if we augment with that microfracture, we can add biologic healing to those meniscus repairs and ultimately increase our meniscus tear healing rates. So another myth that I'd like to address is that radial tears, or the perpendicular tears that go through the meniscus, are irreparable. There's very good data that's coming out that shows that the consequences of not repairing a tear like this, especially for young athletes in their teens and their 20s, is important, and those patients can go on to rapid arthritis even in a year or two. So this is an example of a radial tear. This is a more challenging technique, but there's a couple options out there where you can place 2 small drill tunnels at that tear site, anchor that tissue back down to the tibia, and then place horizontal stitches that go in line with that meniscus, and ultimately get that to hopefully heal back to there. And there's a number of different types of repair options for that have been, I would say, developed in the last 5 to 10 years. And ultimately, when you look at the outcomes, repair of those radial tears can have very similar outcomes to vertical mattress, or kind of what we consider the highest healing rate for meniscus tissue. So, I would attempt to repair that and hope that you get a repair, rather than just assume it's not going to heal and take that whole tissue out, especially for young patients. And then the third myth I'd like to talk about is really the idea of a meniscus root tear. Again, these are a new idea and a new problem that we're kind of understanding over the last 10 to 15 years. We used to call something called SONC, which is spontaneous osteonecrosis of the knee, as just something that kind of happened for patients. We're now understanding that usually those are associated with a meniscus root tear, and that this is a problem that we really shouldn't be missing. Because if you take the attachment site of that meniscus off of the tibia, most of the rest of that meniscus is not functioning. And in some studies, it's up to 28% of all meniscus tears. Another study looked at lateral tears for ACL reconstructions, found them about 7%. And for multi-ligament knee injuries, as Dr. Swan talked about, those are usually high-energy injuries, and these are injuries that about 1 in 5 may have a root tear. So we should be looking for these, and we should be fixing them when we see them. When you look at the biomechanics, Chris Harner, when he was in Pittsburgh, looked at this and found that a root tear was basically equivalent to a total meniscectomy. So although that tissue is there, it's not functioning. And that's an important thing for us to identify and ultimately try to restore. This is a good example of extrusion you see on the MRI here. This tissue is kind of extruded out from the joint, and it's not on the tibial plateau where we want it to be. When you look at the back of the knee, there's blunting of this posterior meniscus, and this is a meniscus root tear. This is something that many radiologists are not identifying because they probably weren't trained in this. So we need to be looking for this and ultimately identifying that, because if we catch that early, we can hopefully prevent the rapid progression of arthritis for that joint. Again, we talked about SONC, and that's an important thing to look for that meniscus root tear. Biomechanically, also, Chris Harner has shown that when we repair these, we can restore the contact pressures for that joint back to normal. I'm going to skip a little bit of this. The summary is a little busy slide, but the summary is that we can improve outcomes for patients who have root tears, and that there is good data to support doing that for ultimately getting them back to a high level. How do we treat meniscus repairs? What's the rehab protocol like? So depending on the type of tear, usually there's some period of non-weight bearing, and this is where you have to counsel their patients. Many patients say, look, I can't do 6 weeks of non-weight bearing. I just can't work that into my life. For peripheral tears or tears that are, may compress that tear when you weight bear, you may be safe to let them weight bear a little earlier. Certainly for root tears or radial tears, those are things that I do wait 6 weeks to let them weight bear. I avoid deep leg presses greater than 70 to 90 degrees when they're loaded for about 4 months. And this is an important thing as you work these patients back to their activities. So, in summary, the function of the meniscus is really 2 main things. It's all about load transmission and ultimately acting as a secondary stabilizer for the knee. If at all possible, especially for young patients, I really try to repair the meniscus, and that's what I believe the data would support. For many patients with a degenerative tear, non-operative treatment is a good first line and has good data to support it. But there are a subgroup of patients who will benefit from arthroscopy for a degenerative tear, especially with those mechanical symptoms that they're having. So with that, I appreciate you guys' attention. Happy to take questions. Thank you very much.